Hi guys, welcome to Radiology 365, where we try to cover core radiology from cover to cover. Today we are going to be talking about diffuse lung diseases, and we are starting off with interstitial lung disease. So let's consider the lung as being the parenchyma and the interstitium. The parenchyma being the actual lung tissue, that is the alveoli, the bronchi, the secondary pulmonary lobule, and then the interstitium being the space between the cells, the space between these structures, where you have blood vessels passing and lymphatics passing. So prior to this, we've been talking about diseases that affect the parenchyma. We've been talking about the pneumonias. We've been talking about the cancers. Now we are talking about diseases that affect the interstitium. Interstitial lung disease may be idiopathic or secondary to known insults, and these known insults may include drug toxicity, collagen vascular disease, or occupational exposures. A disease can only be classified as an idiopathic interstitial lung disease if there is no other explanation for the pathologic changes. Some of the symptoms of interstitial lung disease are non-specific. In fact, most of them are non-specific, like cough and dyspnea. However, factors like age, gender, risk factors, how the disease is progressing, and some of the imaging features can help distinguish between the various entities of interstitial lung disease that will be seen. Now, histologically, the lung responds to injury by recruiting lymphocytes or macrophages and increasing inflammatory debris and instigating a fibrotic reaction. So there's basically inflammation and then healing by fibrosis. That's usually how the lung responds to injury. The things we are going to be discussing are patterns of disease, and these patterns of disease point us to a list of differentials based on disease progression and certain imaging findings and a good history. Okay, so that's how I have come to understand interstitial lung disease. I'm hammering on this because I had a hard time understanding interstitial lung disease and the patterns that were being described. What do they mean by non-specific interstitial pneumonitis or usual interstitial pneumonia? What are they talking about? Is that a disease? What causes it? But I just come to realize that these descriptions or these entities are just descriptions of a pattern that you see, and then once you see this pattern, you can now, based on other features like the history and the disease progression and the patient demographics, you can now give a list of differentials that, okay, I see this pattern, these are the possibilities. Makes sense? All right, so let's dive right in. So the histologic patterns that I mentioned, the 8 of them: usual interstitial pneumonia, non-specific interstitial pneumonia, organizing pneumonia, respiratory bronchiolitis, discomitive interstitial pneumonia, lymphoid interstitial pneumonia, diffuse alveolar damage, and hypersensitivity pneumonitis. We have touched a little bit on hypersensitivity pneumonitis in previous discussions when we're talking about the approach to micronodules. So let's start off with usual interstitial pneumonia pattern. Idiopathic pulmonary fibrosis is the clinical syndrome of usual interstitial pneumonia with unknown cause. So if you see a pattern on your chest CT, and at the end of the day you conclude that this pattern of yours is usual interstitial pneumonia pattern, and you don't have any known cause from history or anything like that, then your diagnosis is idiopathic pulmonary fibrosis. And this idiopathic pulmonary fibrosis is the most common cause of usual interstitial pneumonia. It has a much worse clinical outcome compared to the secondary causes of usual interstitial pneumonia. And the mean survival of idiopathic pulmonary fibrosis is really not much different compared to lung cancer. Now, of all the interstitial pneumonias, only acute interstitial pneumonia, which we'll look at later on, has a very bad prognosis. The clinical symptoms of idiopathic pulmonary fibrosis include dry cough and dyspnea. See how non-specific this symptom is. And it usually affects male patients greater than 50 years and typically smokers. So if you see, again, chest CT, that's you conclude that this pattern of disease you are seeing is usual interstitial pneumonia pattern of disease. Look at the history. If it's a 50-year-old male smoker and you don't have any other reasons why the lung should look like this, you can conclude that this is idiopathic pulmonary fibrosis. Now, there are other triggers of lung injury that may result in a usual interstitial pneumonia pattern. So in this case, it's not idiopathic anymore. So diseases like collagen vascular diseases, for example, rheumatoid arthritis, which occurs more commonly than scleroderma, which is another collagen vascular disease. Then certain drug toxicities could also lead to the usual interstitial pneumonia pattern. In that case, it's no longer idiopathic pulmonary fibrosis, but then you say usual interstitial pneumonia secondary to, if these other factors have been stated in the history, you can mention them as possible causes of this interstitial pneumonia pattern. Asbestosis is also one of the causes. Now, an imaging clue to the presence of asbestosis is calcified plaques. So you see the UIP pattern with calcified pleural plaques, then you could make an impression of prior asbestos exposure. The pathology of UIP features interstitial fibroblastic foci and chronic alveolar inflammation with temporal and spatial heterogeneity. So this is mainly a fibrotic process. So that's what you would see on histopathology. Now, early UIP features reticulation in the posterior subpleural lung bases. And in later diseases of UIP, you would see traction bronchiectasis and subpleural honeycombing. So you realize that these things are mainly signs of fibrosis that we are describing. The reticular opacities, the traction bronchiectasis, which occurred later on, the honeycombing, which is a sign of end-stage fibrosis. See all these things, and the lung bases are the most severely affected. So if we see these in a predominantly lower lobe lung base distribution, then we call this usual interstitial pneumonia pattern, and then we can now list the differentials based on the history. So in this image, it shows a non-contrast CT with subpleural reticulations and honeycombing seen here. This was a case of UIP. Then the next one we'll talk about is non-specific interstitial pneumonitis pattern. Okay, so non-specific interstitial pneumonitis is both the name of the clinical syndrome and the corresponding pathological diagnosis. So it's on histopathology that the diagnosis can confidently be made, but there are radiological things that you would see that would point you to mention that this pattern that you are seeing is non-specific interstitial pneumonitis. The patients in this case are typically younger than those we saw in UIP. We said UIP are males greater than 50 years who smoke. These ones are a little younger, between 40 to 50 years compared to IPF. The symptoms are similar to IPF, chronic dry cough and dyspnea, and it actually has a better 5-year survival compared to IPF. Now, again, unlike IPF, NSIP does respond to steroids, and this is because it's actually an inflammatory process, while the former was more of a fibrotic process. And NSIP is almost always associated with underlying disease. Remember, we mentioned IPF, which is idiopathic pulmonary fibrosis, is the most common presentation of UIP. Of course, there are secondary triggers, but most of the time, if you see UIP, it's most likely due to IPF. However, NSIP, on the other hand, would most likely than not be caused by some underlying disease. And it's the most common pulmonary manifestation in patients with collagen vascular disease. So it may be associated with dermatomyositis, SLE, mixed connective tissue disease, and scleroderma. NSIP may also be caused by a drug reaction. So you realize that some of the secondary causes are cutting across the various interstitial disease patterns that we have described so far. Histologically, NSIP features thickened alveolar septa from chronic inflammation, as opposed to the fibroblasts that suggest a fibroblastic disease in IPF or UIP. Now, an important imaging feature of NSIP is the presence of ground glass opacities with peribronchial predominance, which is a key feature to distinguishing NSIP. So in NSIP, there are ground glass opacities. So if you see ground glass opacities, don't even think about UIP. UIP has honeycombing and reticulations and all that. You may see some of those in NSIP as well, but once you start seeing ground glass opacities, you should be thinking more of NSIP. A key imaging finding, I mean, this is not always seen, but it's very specific, is sparing of the subpleural lung. Remember the honeycombing things we saw in usual interstitial pneumonitis? Yes, those are subpleural. It's subpleural and basal. But in NSIP, if the immediate subpleural part of the lung is spared, it is unlikely to be UIP and more likely to be NSIP. Just like UIP, NSIP also tends to affect the lower lobes, so at least this is something that they have in common. You should consider other diagnoses like chronic hypersensitivity pneumonitis or sarcoidosis if you are seeing primarily upper lobe disease. Alright, so in this image, it's a case of NSIP and it's an axial CT and it shows posterior basal predominant subpleural and peribronchial reticulation with mild ground glass attenuation and mild traction bronchiectasis. You can see these dilated bronchi here. Now, this presentation likely represents the fibrotic subtype of NSIP, and the esophageal dilatation we are seeing here is a clue to the presence of scleroderma, which is often associated with NSIP. Now, the third one we'll talk about is organizing pneumonia. Now, organizing pneumonia is the histological pattern of alveolar inflammation with granulation tissue polyps that fill the distal airways and alveoli. Now, organizing pneumonia may be a response to infection. It could be a response to drug reaction or inhalation. It may also be idiopathic or even related to connective tissue disease as well. So you realize again, the secondary triggers are very similar. And so the pattern that you would see on the lung is what would direct you towards making an impression of organizing pneumonia and listing the possible triggers, or NSIP and listing the possible triggers, or UIP and deciding whether it is IPF or secondary to those triggers. Now, if you have organizing pneumonia pattern with an unknown cause, then you call it cryptogenic organizing pneumonia. That is idiopathic organizing pneumonia. It was previously called bronchiolitis obliterans organizing pneumonia. Cryptogenic organizing pneumonia clinically responds to steroids with a good prognosis, and it may resolve completely, although recurrence is common. On CT, you would see consolidation or ground glass opacities in a peripheral and peribronchovascular distribution. So let's remember the distribution we've talked about so far. NSIP and UIP are lower zone dependent, basal dependent. Organizing pneumonia is peripheral and peribronchovascular in distribution. Now, an important sign to note is the reverse halo sign, which is also known as the atoll sign. This features a central lucency surrounded by a ground glass halo or a peripheral area of consolidation. The reverse halo sign is really not a specific sign, but in the appropriate context, it is highly suggestive of organizing pneumonia. Now, let's not confuse the halo sign with the reverse halo sign. The halo sign is typical for invasive aspergillus, and that one shows a central opacity with peripheral ground glass. So in this image, it's an axial CT, and it shows patchy consolidative opacities in a peribronchovascular distribution, and there is also the reverse halo sign or the atoll sign in the right lower lobe, where we have a central lucency surrounded by a peripheral opacity. Then we move to respiratory bronchiolitis. I'm going to call this respiratory bronchiolitis interstitial lung disease. It's both the clinical syndrome and the pathological diagnosis, and this is a smoking related interstitial lung disease. So if we just say respiratory bronchiolitis, means we're talking about the condition where pathologically we see pigmented macrophages in the respiratory bronchioles. This is respiratory bronchiolitis without the ILD. It's usually asymptomatic, but if you now have RB, which is symptomatic, and by symptomatic we mean the usual dry cough and shortness of breath, then the clinical syndrome is called RB-ILD, respiratory bronchiolitis interstitial lung disease. Histologically, RB-ILD is characterized by sheets of macrophages filling the terminal airways with relative sparing of the alveoli. The key imaging features of RB-ILD are centrilobular nodules in the lung apices. So we have seen the distribution for RB-ILD here is the lung apices. In this image, this axial CT shows innumerable resembles sub-centimeter ground glass nodules, and none of these nodules extend to the pleural surface, so it tells us that it's centrilobular. And this was a case of respiratory bronchiolitis interstitial lung disease. The next one I'll talk about is desquamative interstitial pneumonia. Just like RBILD, desquamative interstitial pneumonia is both the clinical syndrome and the pathological diagnosis. Pathologically, RBILD and desquamative interstitial pneumonia represent a continuous spectrum of smoking-related lung diseases. So just like RB, we have brown pigmented macrophages involved. However, these sheets of abnormal macrophages, apart from being in the respiratory bronchioles, also extend into the alveoli. And once you have alveoli involvement, you should be thinking of ground glass opacities leading to consolidation. When the alveoli are partially filled, leads to ground glass opacities. So that should make the imaging features of desquamative interstitial pneumonia make sense, since now the pigmented macrophages are not only in the bronchioles, they are also going to extend into the alveoli. So we'll not only have these centrilobular ground glass nodules, but these ground glass nodules are now going to be more coalescent. So the imaging of DIP shows diffuse basal predominant ground glass opacification. Although the predominant abnormality is ground glass, a few cysts may also be present. So in this axial CT, it shows extensive ground glass opacities, and this is a non-specific pattern. We also see some ephysematous/cystic areas that are seen here. This is a non-specific pattern, but this turned out to be desquamative interstitial pneumonia pattern of disease. And the last one we'll talk about is acute interstitial pneumonia. It represents idiopathic diffuse alveolar damage, and it's the pathologic diagnosis that is seen in the clinical syndrome of acute respiratory distress syndrome. Now, unlike the other interstitial lung disease that we have spoken about, acute interstitial pneumonia is the only one that has an acute onset, and is the only one that has the worst prognosis. Now, it progresses in two phases. There's the early or the exudative phase, and then there's the chronic or the organizing phase. The early exudative phase features hyaline membranes, diffuse alveolar infiltration by immune cells, and non-cardiogenic edema. So as we are describing these features, you can understand the imaging features that we are going to expect. We are seeing alveolar membranes, we are seeing alveolar infiltration diffusely, and so it will make sense that we would have some diffuse ground glass and coalescent consolidations that may appear in a basal dependent distribution. The chronic phase would feature alveolar wall thickening, which is due to granulation tissue, and this chronic phase usually begins 1 week after the initial injury. On imaging, you would see, like I said, opacities that coalesce with architectural distortion and bronchial dilation. These features will eventually resolve over time and will sometimes resolve with residual fibrosis. So this image of acute interstitial pneumonia is the early or exudative phase. It's an axial CT, and it shows extensive geographic ground glass attenuation. It's a non-specific pattern, and it may represent pulmonary edema, it may represent pulmonary hemorrhage, it may represent infection. At the end of the day, history is very important for us to come to the conclusion that this is acute interstitial pneumonia from ARDS. Alright, so this table summarizes everything we have mentioned. So you realize everything we have mentioned fall under the histologic pattern, and there are certain clinical triggers that will give us these patterns. So once you describe the pattern, say you now add these as your possible differentials based on the history, right? So yes, you can just pause it here and then take a quick look at the clinical correlates and then the main imaging findings of the various patterns that we have described. Thank you very much for your attention. I hope this was helpful. The next topic we'll talk about is antigen and exposure related lung disease. If it was helpful to you, give it a thumbs up, share with someone you think would like it. If you have any questions, put them in the comments, give me a thumbs up, and I will see you in the next one.